let me move on. So tonight we have joining us, we have Natalie Proffitt from VCU Health. I'm going to let her introduce all of the things that she does, but she's going to cover the whys of stroke care. You guys have all taken stroke classes before. You've all had lectures on strokes. Um, and a lot of times we just kind of say something about, about a stroke or about what you need to do when you're dealing with a patient that has a stroke, but we may not go into why we do that. So tonight, Natalie is going to tell you guys a lot of the whys for stroke care, why we do what we do, and how that can impact your patient and impact outcomes. So I'm going to turn you over to Natalie. Natalie, they are all yours.
Perfect.
Please feel free to introduce yourself and start your slides when you're ready.
Okay. Thanks, Greg. So hi everyone, Natalie Proffitt. I work for VCU. I work currently in supplemental staffing in the ICU ED float pool. So I kind of work all over the hospital. My background before nursing, I worked in various ERs locally, but I also I worked for fire rescue, Goochland County and Albemarle County volunteer, and then a couple years paid with Albemarle County before that. So a lot of exposure to EMS and obviously been in a couple different health systems and now with VCU for the last um, 3 years as a nurse. And I spent some time in the neuroscience ICU, and then I help the stroke team pretty regularly with a lot of their data and stuff like that. So that's my background. I'm passionate about stroke. A couple close family members having stroke. And so, yeah, here we are. I'm going to talk about the whys. I think there's a big disconnect sometimes from the EMS to not just the ED, but like what we do beyond EMS, what we do beyond the dropping our patients off, and lack of understanding. So I think this will be good to bridge the gap, the knowledge gap there, why it is so important, why you guys do what you do, and how it kind of impacts your patient on the hospital side after you drop them off at the door. Um, Greg, you just make sure everything looks
Yeah,
fine.
we can see you. And just a couple of comments. We've got a couple of extra people from the stroke program on tonight. So if you guys have a question while Natalie's presenting, you can put that in the chat. And Stacy Stevens, who works with the stroke program, is our outreach coordinator for our stroke program. And Lori Selleck, who is also with the stroke program, can go ahead and answer those questions for you live in the chat. Otherwise, you can save your questions for the end. And also, Natalie has agreed to share these slides with you guys at the end. So if you're interested in getting the slides, shoot me an email to my email address so that I can just reply and send it to you. And Natalie, they're all yours. Sorry about
Yeah.
that.
No, that sounds good. And I'll have he said, you can, if you have a quick question, just so it doesn't get forgotten, feel free to put it in the chat. Stacy and Lori can answer, or I'll have like a little question slide. After most of the content's done, you guys can jump in and ask if you want then. Okay, so the whys behind pre-hospital stroke care. We'll jump right in. So we're going to talk about what is stroke, why is it an emergency? I don't know why that big yellow mark's in the middle. Um, and we're going to review kind of like what you guys do as pre-hospital providers as it applies to stroke care, but then the whys, the big whys, and specifically behind your pre-hospital stroke care. And if we can get to some case studies, we will. So what is a stroke on basic level? It's when blood and oxygen don't get to the brain or a certain area of the brain. The cells, they die within minutes, within, I think it's 2 million brain cells a minute. Or sorry, 2 million neurons, maybe that's a minute, will die. And stroke leads to disability, sometimes death, worst case scenario. It can occur by blockages and ruptures. There's two different types. We have the ischemic stroke, and that's when an artery becomes narrowed or blocked by a blood clot. It can be narrowed because of different vascular processes, but it cuts off blood supply to a certain part of the brain. And then anything beyond that, the cells start dying. That blood flow, that's not happening. So these ischemic strokes account for like 85% of the strokes we see as EMS providers. VCU, that number is a little lower. The ratio is a little lower with the hemorrhagic strokes. We get a lot of transfers in for brain bleeds, so we see a little more on the brain bleed side. So that number is a little lower for VCU on the ischemic side, excuse me. And then hemorrhagic stroke is exactly what it says it is. It's a brain bleed. Weakened blood vessels can rupture. Vascular abnormalities can cause this. Hypertension can cause this. Plethora of reasons. And the blood leaks into the brain, but obviously that compromises the blood flow beyond where that vessel is ruptured. So the same thing, the cells start to die. One of the big things you'll hear your patients say for the brain bleed specifically is the worst headache of my life, or the thunderclap headache. A lot of people coin it. So that's kind of a specific to hemorrhagic stroke. And these, like I said, these ones account for the 15% of other strokes we see. So on the lower side, but still as important, there's still surgical interventions, plenty of care that goes into these hemorrhagic strokes. There's two subtypes, the intracerebral within the brain, and then subarachnoid. Those are a lot of the traumas you'll see. Your motor vehicle accidents, falls, things like that, you'll see the subarachnoids in. And then the other category, transient ischemic attack, TIA. A lot of people refer to TIAs as mini strokes. I personally see and think there's a lot of misconception and kind of lack of education with TIAs. Versus versus a real stroke. But it is a warning sign. It is a good indicator that a stroke may come. Very highly likely, to be honest, that a stroke will come at some point. The symptoms are usually exactly the same as an ischemic stroke symptoms would be, but they resolve. What makes them a TIA instead of a stroke is they resolve within minutes to hours, and on their MRI, eventually they'll show no brain damage, no cell death. But the TIA itself is a big indicator that a stroke could come. So we're going to kind of one of the big subjects we talk about here in this lecture is going to be large vessel occlusions. You'll hear me refer to, sorry, my screen. You'll hear me refer to it as an LVO. This is your kind of, Greg, sorry to pause. There's stuff going on my screen. I don't know if y'all see it or if I just see it.
Yeah, it has to do with when you move your mouse around on the screen.
I don't know why it's
think
doing.
that
I'm
can
not moving.
show.
I'm not touching. I don't think I'm touching my mouse. Sorry about that.
Okay. It
Um,
could be somebody else adding notes too, so it might be
yeah,
running.
I'm not even moving my mouse, so I don't know. So anyway, large vessel occlusion. So we have the larger vessels. You can see here on the bottom, you have your posterior vessels, and they kind of go up into your midbrain, and you've got the ones that are circled. Those are going to be your large vessels. So your middle cerebral artery and your internal carotid artery, MCA, ICA are the terms. What you'll hear them called, and then the basilar artery and the vertebral artery. Those are those posterior. So this is important because these are the people that can get the thrombectomies. They get the mechanical, oh my gosh, I'm blanking on what a MR is called right now. Forgive my nerves. Stacy, feel free to chime in. I'm having mechanical reperfusion.
Endovascular reperfusion.
Endovascular reperfusion. So we call it a MR within the stroke team, but it's a thrombectomy. It's where they go in and retrieve the clot, stent the vessel to keep it open. So those are these patients you'll see later on. They are important. We can address it as EMS providers. There's just not a lot of education out there yet pushing on the EMS side of things, but it does make a difference. These LVOs, these large vessel occlusions, a lot of times they'll get TNK or the clot busting medicine, TPA, alteplase, however you guys know it. They'll still get that, but a lot of times they're not as responsive with these large vessels. So why is stroke an emergency? Heart disease and stroke claimed more lives in 2022. This is the latest data as of 25, but applies to 22. Claim more lives in the US than all forms of cancer and chronic lower respiratory disease combined. So huge problem within the US. and it's the fifth leading cause of death, and it's maintained that fifth spot for years and years. So one of the top leading causes of death causes 1 out of 20 deaths, 1 out of every 20 deaths in the United States. It is the leading cause. It has been for a long time the leading cause of disability. And 25% of strokes a year are people who have already had a previous stroke. So you're about 10 times more likely to have a stroke if you've already had one. And then we like to point out that 80% of strokes are preventable. Excuse me, there are a couple non-modifiable risk factors. You know, your gender, your age, your race and ethnicity, some of those put you at higher risk for stroke. But your blood pressure, your diabetes, all of those things, they're modifiable. They are, you can improve them, you can make them go away. So strokes are preventable, and those are all things that put you at higher risk for stroke. We like to add this picture in there. It kind of shows we live kind of right in that stroke belt. You can see this is the stroke rate deaths, and that dark purple is the higher death rate. And so they call that the stroke belt, and Virginia sits right inside of it. So we do see a fair amount of strokes here in Virginia. Our why, what we preach as a stroke team, and what a lot of people preach, time is brain. Literally every second matters. In a typical ischemic stroke, every 15 minutes shaved off that time from when the patient comes in the door till they get that clot busting medicine, that TPA, TNK, wherever, alteplase, wherever you go that they give. It saves 30 million neurons per 15 minutes, decreases their mortality by 5%, and improves their functional outcomes by 4%. So literally every minute matters, and that applies to your minutes on scene, your minutes en route and transport, and our minutes for that patient in the hospital too. Okay, so this is where we're gonna hang out, is in the EMS priority side of things. This is kind of what you guys do as providers. You do your primary survey, and this is as applied to stroke. Your primary survey, you know, how sick is your patient? You're going to identify your stroke symptoms. You'll use your stroke scales to help you with that. You'll check a blood glucose level. Obtain your detailed history of what's going on at the current moment, why they called 911, and then you're going to get your pertinent medical history. You're going to make your transport decision, how you're getting to the hospital, and which hospital you're choosing to go to. And then your treatment. You're going to treat your patient as you go. So we're going to kind of go through all those. So why is your primary survey important as it relates to stroke? Obviously, everyone knows your ABCs. Your airway, super important, especially like our hemorrhagic strokes. They can lose their airway. They can rapidly decline, and their mental status can change very quickly. So airway is really important, especially if you're suspecting the hemorrhagic or the LVOs, some of the more severe strokes. So making sure they have they're maintaining their own airway, and you think they're going to be able to maintain their own airway in transport, on scene, and the whole way to the hospital, whichever you choose, whatever destination you choose. Obviously, supporting their breathing, support ventilations, oxygenation as needed en route. We all know that. And then you want a good baseline blood pressure and heart rate. Those are going to obviously help you trend what's going on with your patient en route, but it's also good to know for the hospital when they get there. You know, hypertension is going to be a lot of what you see in stroke. It's one of the biggest causes of stroke. So just pay attention to that. And then I add the disability. It's part of y'all's survey, but paying close attention to, did they have a fall? Do they need a C-collar? But then when you get them up to the stretcher, when you get them out to the ambulance, how are they leaning to one side? Are they able to walk? Are they dragging a foot? Kind of all those little things matter. So you're going to get all that done. We all know that goes pretty quickly. And then you're going to move on. Once you think, kind of add stroke into your differential because of what you're initially going to the scene for. Is the patient having a stroke? You want to use your stroke screening tools. The one we all know, Cincinnati Prehospital Stroke Scale. That's your FAST scale. That's what the community is taught. That's what basic EMS providers are taught. And that's even what we teach for the most part within the hospital. And then there's BFAST, something a little bit on the newer side. And we'll get into a little bit more details on them. But be fast, I think everyone will see if they haven't already, that's going to be the new push for kind of the basic stroke assessment. It's a little more inclusive. Once you decide, yes, they're having stroke symptoms using your screening tools, then you're going to move on. And you should be doing these stroke severity scales. So once you think they're having a stroke, what is the likelihood that they're having one of those large vessel occlusions, one of those LVOs that we talked about? And use scale. Race scale isn't one. I think we don't really use it in ODEMSA. I don't see it. I don't see it in any agencies where they're actively using it. The VAN scale is the one that I see them pushing out more, but some localities do use race. Stacy was telling me the PEMS region uses the race scale. So these are going to tell you the likelihood of them having that LVO, and that's going to change, hopefully change your decision or force your decision on which hospital you go to, what kind of hospital you go to. All right, so your FAST scale, everyone should be familiar with that, but you got your facial droop. So what most time we ask people, smile real big with your teeth. You can usually see the weakness on one side of their face at the lip line, or you can say raise your eyebrows, and you can usually see the abnormality or the unilateral weak paralysis on if they raise their eyebrows on the upper part of their face. So normal, obviously both sides, everything moves equally, looks equal and symmetrical. Abnormal would be any unilateral difference. And then arm drift, most of the time you ask your patient, hold your arms up high in the air. Sometimes people say, hold it like a pizza box, close your eyes. In my experience, usually if there's arm drift, it's usually if they're 5 to 10 seconds holding their arms up, as far as the EMS side goes, you can tell drift is pretty significant. If both arms move the same or they don't move at all for whatever reason, that's still considered normal. You're looking for that unilateral problem, that arm drift or significant weakness. They can't lift it up, anything like that. The speech, normal, obviously normal speech. Abnormal is going to be anything slurred words, word salad, completely inappropriate words. If they're unable to speak at all, those would all be kind of a positive on that speech side. And then the time, obviously time is brain. So time is last known well is what you want to take note of, but the time portion is also let's load and go. Let's get the patient to the hospital. So this is that be fast where we add in balance and eyes. So they found that posterior strokes, those basilar vertebral occlusions, were getting missed in the FAST scale alone. So the loss of balance and any visual deficits are big indicators of those posterior strokes. And sometimes they are the only symptom they have. And so they would fail the FAST scale, the FAST exam, and be deemed not having a stroke. And then they get their MRI, positive stroke. So they added the B part, balance and eyes. Just pay attention again to their gait when they're walking. Are they steady? Are they leaning to one side, dragging a foot, unable to walk, but they normally can walk? And then vision, losing vision in one or both eyes. And we'll get a little bit more when we get to the VAN scale, but if they have a portion of their vision, anything like that, any vision changes, just heighten your suspicion for stroke. I just put the race scale. Like I said, I don't think if you are in this region, you might not be familiar, but it's kind of a piggyback off of the NIH scale we use in the hospital. It's scored, and then anything above a 0 is a stroke alert worthy criteria, but anything above a 5 would give you that indication for an LVO. So it seems like a good scale. I've never personally used it, but I did include it here for anyone who does, or you just want to know about it. Excuse me. This VAN scale is what we use and what I try to kind of push to the EMS side of it. I think it's very applicable, something you guys can easily do. It's a couple yes/no questions, and it can really, really make a huge difference for your patient if you make the right transport decision based on this scale. So you're looking for the weakness. It's a piggyback off of your Cincinnati. So you have that unilateral weakness or anything like that, that should jump you right to this VAN scale afterwards. And you're looking for the VAN, visual disturbances, your aphasia, and your neglect. So like I said, visual disturbance, really any vision changes, blindness, blurriness, double vision. If you hold finger out to the left or to the right, and they can't see in their periphery. And then the aphasia, expressive aphasia, is when they have trouble or are completely unable to get words out. This is not just slurred words. This is actually like aphasia. So can't get words out, or if you're talking to them and they can't follow the commands you're saying, like they're not understanding you, or they're not appropriately answering your questions, they're not receiving the information. That's receptive aphasia. You can have a mixture of both. You can have global aphasia where they're really not getting, nothing's coming in or out really well, or just no speech at all. And then neglect, when you have a forced gaze to one side, they're not able to track your finger left and right completely or up and down completely. And then if you touch both their legs, kind of give them a little pinch on both sides or both arms, and they can't feel one at all, or you're, touching them on one side, they can't feel it, or they're not acknowledging you, that would be neglect. So the big thing with this scale, it is both sensitive, what's the other word I'm looking for?
Specificity.
Yeah, specific and sensitive. Thank you, Stacy.
Sure.
It is a good scale for that. So I don't know the exact, and I don't know if you do, Stacy, but I vaguely remember, I think it's like over 75% chance if they have one of these that they're having a large vessel occlusion. I don't know if that's the exact number, but I know it's a pretty likely. And then if they have 2 or 3, like it's almost a certainty. It's like, I think it's above 90% on they're having a large vessel occlusion. So just keep it in mind. It is a good tool to have in your toolbox, and to piggyback off of that fast. And then we'll get into some of your transport stuff later on. But these people with these LVOs, they're going to need a comprehensive stroke center, someone who can go in with a thrombectomy, and get that clot out. So why perform the stroke scale? Touched on a little bit of this, but it should guide your treatment plan as an EMS provider, and it should definitely, especially those LVO scales, it should guide your transport decision, both how you go and where you go. Your stroke scales give you the opportunity to call a stroke alert in as early as possible to the hospitals. Sometimes, 10 at VCU, at least like 10 minutes to get neurology down to the ER. So as much notice as you can give your hospital, your receiving destination, the better. So that stroke scale is good for that. You're able to call your report. We have a stroke coming in, even if you need to call back and give more details later. It's good, that early recognition. You can do serial scales. When you first get to a patient, you do a stroke scale. You start your treatment en route. You can do another one or right before you get to the hospital. It's good to kind of trend, progression of symptoms. Even for a TIA, are they improving? That matters to us at the hospital. If their symptoms were something and now they're better, or they're worse, either way. And then obviously I said the BFAST scale, great tool to catch those posterior strokes. Those people are still eligible for every single treatment that the other strokes are. And there's still, the LVO is still posterior possibility. So commonly missed stroke. And then the VAN, obviously the VAN or race scale, like I was saying, those indicate you need to go to an appropriate facility that can do those thrombectomy and endovascular capabilities with neurosurgery. So why check a blood glucose level? Hopefully that's kind of a standard, anyone with altered mental status and anything like that. I know that's an EMS standard practice, but if you suspect a stroke at all, you should be checking a blood sugar no matter what their other symptoms are. If you have any sort of inclination that they're having a stroke, check a blood sugar. We want to rule out hypoglycemia. It's the most common stroke mimic as far as the EMS emergencies we see go. And it's also the easiest to rule out and treat. So you're going to check your blood sugar as quick as possible when you're on scene. Once you've identified that, you're going to treat it. If it's low, I think in the hospital we're 70, I don't know, whatever your locality is, but treat your hypoglycemia. And then you're going to reassess your stroke scale. Hopefully your blood sugars come up. And then once it's come up, or if anything has changed, you're going to do your stroke scale. If they're above 50, we will call a stroke alert at VCU. I can't speak to every hospital. I don't know if it's that way everywhere, but the expectation is that you need to rule out the hypoglycemia before we can call stroke alert. So it's one of the big things. Treat the blood sugar, and then if they're still having symptoms, they will be stroke alerted. So very pertinent. And it has happened where people have showed up with no blood sugar check. So it does happen. And then you're going to get your detailed history of what's currently going on. Crucial information you should be collecting on everyone that you, especially the ones you suspect stroke, their last known well time. If you're on scene and there's witnesses, hopefully, or bystanders or family, they can tell you when the person was last seen at their normal. So you want that information. You want the most exact time you can get. If it comes down to asking them when they had a phone call or when they got in their car, all the advanced technology these days, we've been very good at getting exact times of last known well, because sometimes minutes matter. And then time of symptom onset, we'll get a little bit more into that in the next slide. But they are two different times in a lot of cases. A lot of cases, they're the same time. Just depends on if it's witnessed, unwitnessed, wake up stroke. We'll get a little bit more into it. You want a medication list. If they have a printed list, written list, if someone on scene can verbalize to you. The quick and dirty is if you can only take one thing with you, find out if they're on an anticoagulant and bring that with you. That is the one pertinent medication that matters to us in the first 10 minutes the patient gets to the hospital is that medication. So if you can't do anything, if they have meds sitting on a counter, take a picture of them, whatever you got to do. But, if the patient's never been to the hospital before and we have no records on them, it delays their care for us to have to fact find before they can get, that clot busting medicine or the thrombectomy, all that stuff. So medication list, and then their medical history, the best of your ability. We all know how that goes on scene. But the pertinent things, if you're asking for pertinent negatives, the atrial fibrillation is important. Have you had a stroke before or a TIA? When was your stroke if you had one? Do you have hypertension? Like top cause of stroke, hypertension. Do you have diabetes? Obviously that matters. DVT, PE, that matters. So some of your pertinent, if they can't give you a good history, if they're poor historians, go fact find, ask the pertinent negatives. Bring their cell phone. If they're altered and can't answer your questions and there's a cell phone on scene, bring it to the hospital. If there's a way we can get in touch with the family or get in touch with someone who knows something, I have seen that done a handful of times, been helpful. But ultimately the goal, grab all this information. Those are your must-have, should-haves, do everything you can to get for the patient's sake, but load and go. Minimize your time on scene. Once you get enough practice with it, your stroke scale should be kind of a quick 20 seconds. A lot of people can do them in. Once you get them, they're really easy to recognize. All right, so your last known well versus your symptom onset. Last known well is the kind of the common term. That's what we all know. That's what we all been taught. And that's the correct term. And last time the patient was known at their baseline, completely normal. The symptom onset, if it's witnessed, is most of the time you'll see this. They, I don't know, went to work and someone witnessed them at work having all their symptoms. Then they know maybe they know exactly what time they fell. They know exactly what time they started slurring their words. Symptom onset. Last known well is applicable to a lot of the patients that you last seen them, at a party. They left their party, they were fine. They left my house, they were fine. I talked to them on the phone, they were fine. So that time matters. But I just want to point out that they are two different times in our view on the hospital. So when you say last known well, make sure you know that's the last time someone saw them at their baseline. If you don't know, there's the time exactly that their symptoms started. I'll tell you though, wake up stroke is, I put it in quotes, that's kind of what we refer to when people go to bed normal. People see them before they go to bed, they're normal. or the patient can speak to it too. I felt fine when I went to bed. They woke up, they have stroke symptoms. We call them wake up strokes, if you ever hear that term, which I think I'll talk about here. So why is that time so important? Most facilities, many facilities, I can speak to VCU, we will stroke alert patients up to 24 hours from their last known well or symptom onset. And as well as unknown last known wells. So those wake up strokes, they're stroke alerts. Yeah, if they're found down and no one knows how long they've been there, no one's talked to them in 2 days, we can still stroke alert them. So don't rule out anything as when it comes to a stroke alert. Just take note of all your symptoms like we talked about with the stroke scales, and then we'll make that determination. But the hospitals are very liberal with their stroke alerts now. They're very inclusive with these people. So, and then this time is the crucial kind of component in determining their eligibility for thrombolytic therapy. It used to be alteplase. Most facilities have moved to TNK, to nectaplase. They're both TPA, tissue plasminogen activators. So if you hear the terms, they're kind of interchangeable, but alteplase versus tenecteplase is what we've gone to. That thrombolytic medication can be given up to 4.5 hours from their last known well, potentially. So that time really matters. It can matter down to the minutes, but depending on when you're picking them up and when their last known well was, and it definitely matters with your facility choice. So just keep that in mind. And then the thrombectomy, the endovascular therapy where they can go in and retrieve those clots surgically, that has real no time limit. They use the imaging once the patient gets to the hospital to drive their care as far as if they're eligible for a thrombectomy or not. So just keep that in mind, that's why that LVO scale and kind of this education is so applicable, because you want to get them to the right facility, and the time matters, and their symptoms matter. Why does medical history matter? Touched on this a little bit, but the atrial fibrillation, if everyone should kind of know the gist of it, but your heart's kind of quivering, the blood settles, high risk for clotting there, clots get thrown everywhere else in your body. Your previous stroke, 10 times higher risk of having a recurrent stroke. So that should have, your radar up for possible stroke. The diabetes, that is not only to rule out your stroke mimic and get your blood sugar, but it's also a huge risk factor for having a stroke. Same thing with hypertension, leading cause for stroke. DVT and PE, they're both clotting diseases or clotting issues. So obviously increased risk for stroke there. And then you'll hear a lot of people, I'm going to add this in and kind of go a little bit deeper into it. We hear it daily in the hospital, so many patients. I'm on blood thinners, or even on the EMS side, they're on blood thinners. That is a broad term that we're going to clarify here. But you find, I'm sure everyone has had this experience if you're in EMS or if you're in the health system, where people, do you have diabetes? Do you have hypertension? No. Well, why are you on metoprolol? Why are you on metformin? So a lot of these patients, you'll find, like, ask the questions, ask the yes or no questions. Do you have atrial fibrillation? Are you on a blood thinner anticoagulant? Do the fact finding. A lot of these people aren't as educated as people think they are on their medications and on their medical history. So, but you say those trigger words and then they'll be like, oh yeah, I do have that. So just be intentional with what you're asking and how you're fact finding. So this blood thinners, we hear it all the time. There is a big difference and there's a lot of confusion around it. So anticoagulation and antiplatelet are two different drug classes, or two different types of drugs. They attack different parts of the clotting cycle. And we'll get into why it's more important, but I just want to say the anticoagulants delay the clotting of blood. They target and inhibit clotting factors, while your antiplatelet medications prevent platelets from sticking together. So sounds very similar, but they definitely have different mechanisms, and it definitely applies to their stroke, their treatment at the hospital. These are the most common, warfarin, Coumadin is the common name, and then apixaban, your Eliquis, rivaroxaban, Xarelto, and then you've got your aspirin, Plavix, and Brilinta on the antiplatelet side of it. The anticoagulants are going to kind of be your key one. So just educate on which is what, or make sure when you come to the hospital, you're specific on which medication they are on, the name of the medication. It does make a difference. And why? Here's why. Antiplatelets do not exclude a patient from being eligible for TNK, for that thrombolytic therapy, that IV thrombolytics. A lot of patients are on, like, post or previous stroke patients, they're on a dual antiplatelet therapy. It does not exclude a patient to be on aspirin, to be on Plavix, from getting that medication. And even on an anticoagulant, they could be excluded, but they may not be. It still doesn't 100% rule them out. If patients have missed, I think it's a couple days of their doses, they still can be eligible. If they're non-compliant with their medication, still could be eligible. If they're on it, we'll run a test called an INR. If it's subtherapeutic under a certain level in the hospital, they can still get TNK. So don't look at a patient and ever think because they're on anything that they can't get that life-saving, clot-busting medicine. And then both of these patient populations, if they're on it, they're still eligible for the endovascular therapy, for that thrombectomy. So just don't rule it out. If hemorrhagic stroke, we can reverse that INR level or reverse the anticoagulant they're on too. So just that medication name, it matters more than just they're on a blood thinner. It really does matter. Okay, so where am I at time? I'm doing okay. Your transport decision, how you're getting to the hospital and which hospital you're choosing to go to. The biggest thing I think is going to be your transport time. Rural localities, we see patients or providers that have over an hour transport. If you're looking, and that's maybe to your closest facility, maybe to your comprehensive, I don't know. But if you're looking at an hour transport time by ground, can you get a helicopter and cut 45 minutes off your transport time? What it was their last known well, within that window, that it's crucial that you get there faster. If you know that they're 3 hours last known well and you have an hour-long transport, you're pushing their eligibility. Maybe flying them is the best option for that patient. So kind of put all your factors together and make that decision there. The other thing with your helicopters, I don't know how all of your localities work, but the RSI medic, your helicopters always have those advanced providers. Do you call them for help on scene? I know we use a lot of them, for their capabilities on the helicopter. Do you need to call an ALS provider if you're only a BLS provider? Do you need to meet for an RSI medic somewhere at another locality? All the things, their airway management, advanced procedures that you think you might need en route. So just consider all of that. We'll get a little bit deeper into the destinations in the next slide. But you're going to have your acute stroke ready centers versus your primary stroke centers versus your comprehensive. They all have different capabilities, and you should be familiar, at least in your area and your hospital choices, with what each facility is capable of, and kind of if you have an LVO, which facility are you going to? What are you going to bypass if you think they need TNK? Kind of all those things. So your transport decision is going to be absolutely crucial. We'll get into that coming up. So your acute stroke ready centers are your fully functioning EDs, but usually like your freestanding ERs. They can give TNK, they can get their CT and get them read and show no bleeding. They can start what used to be the all-to-place, but they can give the TNK IV push now. And then they're kind of the quote unquote drip and ship. So that's pretty much all they can do. They can't admit a patient. They can't do thrombectomies. They don't have neurologists and neurosurgeons there. It's literally just kind of your freestanding ERs. Those are acute stroke ready though, so don't forget they can give TNK. So if you know you're pushing that window and you're 5-10 minutes from a freestanding, don't be afraid to go there to get that patient, that care that they need or could have. I mean, that TNK is life-saving. It can be really incredible, the stuff it's helped patients with. And then you have your primary stroke center. That's going to have an acute, like more of an acute stroke team with protocols. They will have a lot more stroke center training. They do stroke prevention education with patients. They'll have rehab services. They obviously can give the TNK just like the freestanding ER can. The two biggest things is what designates a primary stroke center, what allows them to be that is they have neurosurgery available within 2 hours of the patient getting there or of them being basically consulted to come in. Some of these facilities are thrombectomy capable. You just have to be careful and you have to know, like you have to find out who can actually do the thrombectomies. There's some that the neurosurgeons will come in and do it. There's some facilities that interventional radiologists will do it. And they don't have care like neurosurgery specific things beyond like that IR provider doing it. So just kind of be familiar with what your local facilities can do for you guys. And oh, I lost my train of thought. I was going to say one more thing. Yeah, lost my train of thought. Sorry. And then you have your comprehensive, which is VCU. These are the research facilities, the big hospitals, most services 24/7, providers in hospital. You have your neurosurgeons, neurology. They're in hospital 24/7. They're not just on call. We care for like the complex stroke patients. We have usually they have the neuro ICU, specialty ICUs, and they do the brain surgeries. They do the mechanical embolectomies, which are the thrombectomies. You'll hear them all changed. The MIR, like I was saying, they can do the hemicranies and the aneurysm clipping coiling for some of those bleeds. That's why we get a lot of those transfers in at VCU. We can do that advanced hemorrhagic stroke care too. And then we're peer reviewed, a lot of certified nursing staff. The big thing is VCU and other comprehensive stroke centers can never go on diversion. So they can never turn you away for an acute stroke. You will always be able to go there no matter what. So that's kind of where you're at. What you need to consider, the big things, these little ambulances in between. You take someone to an acute stroke ready center or a primary stroke center, and maybe they need a thrombectomy and they have to go to a comprehensive. You have got the transport time between those facilities that could potentially delay that definitive care for your patient. So you got to think on a big, broad picture when you're deciding on which hospital to go to. You kind of got to pull in all the factors. Their last known well, what you think they might be eligible for. Are they having that LVO from your scale here, from your VAN scale? Pull it all in together. So I added this in there more because I think I hear a lot of people, they have a negative CT. A lot of people think that means negative means no stroke. A lot of EMS providers are there for the initial CT, maybe. I know at VCU, we meet a lot of those EMS agencies, the stretcher right at the door, and they go straight to CT. So they're able to, know that initial result right before they get back in the ambulance and leave. But at negative CT, all that means is that non-contrast CT, that one on the left, that's the dry scan, no contrast, quick CT, takes a minute. And we're strictly looking for bleeding here. We're looking for the hemorrhagic stroke. If there's no hemorrhage in the brain, no bleeding in the brain, that patient could be eligible for the clot busting medicine, that TNK. There's a whole other criteria, that the neurologists go through, the ED goes through as far as eligibility, but that's what they're looking for in that non-contrast dry, quote unquote, dry head CT. Negative means no bleeding. Then sometimes depending on their eligibility, we give TNK, we can IV push it. It's a very kind of easy thing now, a lot easier than Alteplase used to be. So we can give it after we get that confirmation there. And then they'll stay on the scanner most of the time, and they'll get their CTA and a VCU. We have the capability of doing this perfusion, CTP. The CTA is where you're looking for your clot burden. You'll be able to see all the vasculature in the brain and where the clot is. Exactly. So the CTA, most facilities are capable of doing that. And that's where you're going to find your large vessel occlusion. That's where you're going to see what vessel is occluded. Is it a large vessel? Is it a smaller vessel? If it's a large vessel, that's where they make the decision to call the neurosurgery team and get them in to let them decide if they want to do a thrombectomy on this patient. The CTP is a special capability. Not all facilities can do it, but it's very cool, very advanced. There's a lot of AI, I think, that goes into it, but it shows like a time to drain, basically. So how much blood is actually perfusing parts of the brain, along with, if they're having a clot. It's going to show you parts of the brain that are basically dead tissue, not salvageable, and then a penumbra, salvageable tissue that if we go in and fix the problem, that tissue could be recovered for that patient. So that's kind of the advanced scans that at least I can speak to VCU has the capability to do. And neurosurgery, this is why that there's not really a time frame. We've had patients, as far as I've spoken with the stroke team, that have come in 24 hours of symptoms, 24 hours last known well, but their scan shows a large penumbra, very small core infarct. They're eligible to go in and try and pull that clot out and salvage that brain tissue. So that's why, it matters where you take that patient and how long. And that's what they go by, these scans, the neurosurgeons, that they go by these scans and they decide if the patient's going to be a good candidate to go in and do those risky thrombectomy. So this is just a kind of rural locality slide. Not going to get too into the weeds. I just want you to visually see two different patients, both VAN positive scales, both LVO. One of them, I think they were both 30-ish miles from a primary stroke center. Two different cases, though, obviously. One chose to call EMS, helicopter EMS and go directly to a comprehensive stroke center with that VAN positive scale. And another one chose to go the shorter route to the primary stroke center. They both got TPA right around that hour-and-a-half mark, probably at the time, TPA. So both got TPA right around the same time, but they both had LVOs on their scans. That top patient was able to get in for a thrombectomy in under 70 minutes from the time EMS picked him up. Remember, we talked about the brain cells that are saved every minute that you shave off of your time. And then you see on the bottom, they went to the primary stroke center, they got their TPA around the same time, and then they had roughly a 3-hour wait. They're waiting on EMS to transfer them to the comprehensive where they needed to go to get their thrombectomy. They had to repeat scans there because it had been an extended time. They want to make sure they're still a candidate for a thrombectomy. And then they were 147 minutes after arrival there. So just under 8 hours from when EMS picked them up to getting that thrombectomy. So it just kind of goes to show you your transport decision. Although it was a longer transport by helicopter, they did end up getting that TPA right in the same time frame, and they got that MR extremely fast in comparison. So you gotta kind of look at the whole picture and juggle all that when you make that decision. I think there's some numbers on it. I was just gonna look at how many. 326 minutes difference in these two patients. So 2 million neurons every minute is 652 million neurons saved in this patient. So really good thing there. And then we'll just touch on, we got 8 minutes left. I want to leave some time for questions. Your treatment during transport. Notification of that stroke alert to the hospital. Why we talked about hospitals can prepare their resources. You're going to cardiac monitor your patient if you're able to. Obviously, understand EMT basics. Never, ever, ever delay your stroke care for an ALS provider unless you need unless you're trying to take an airway or do something like that. Don't pick an ALS provider up for cardiac monitoring. Don't ever delay your stroke care. They need that. They need the hospital. They need the definitive care. They need the scans, potentially TNK, thrombectomy. But if you have the capability, get your cardiac monitor on. You're looking for your arrhythmias, your AFib, just to kind of build a good picture. If you're a medic or you have ALS on board, or you choose that route, again, don't delay your care. Don't add it just for this. But if you're capable, a 20 gauge IV, we like them in the AC or higher for scanning purposes with that contrast. If you can get 2, perfectly great. Saves us time on our end when they get to the hospital, saves your patient time to get to treatment. We can reduce our door to needle time if we already have access. And then we can get our contrast imaging. You just move them over to CT scanner and we can do everything if you have all that started. You're going to want to keep your head of the bed, head of the stretcher, elevated 30 degrees ideally or more. Treat nausea, vomiting. This is just these stroke patients. They're drooling. They have trouble swallowing. They have trouble speaking. They're all at risk for aspirating. So just be mindful of that aspiration precaution. And then you're going to want to reassess your blood glucose if you were having trouble with that. And then reassess your stroke scale. Like I said before, the TIAs are the improvement of the symptoms matter just as much as the worsening of symptoms matter. And it's going to guide your treatment plan and it's going to guide ours at the hospital too. So just reassess. Some other considerations, trauma versus stroke, kind of what came first, the chicken or the egg. And then pediatric stroke, I'll just give you a quick little 1 sentence on that. Your trauma versus your stroke, what came first? Are your indicators on scene matching what happened? If you have an altered mental status, restrained driver, low impact, no signs of head injury, why are they altered? Did the witness who called 911 say he was swerving beforehand and then hit a tree or hit a whatever low speed, and you're wondering why they're altered? There's no other signs of why they're altered. Just heighten your awareness, add stroke to your differential. Don't rule it out. Other traumas, you see people, they lose consciousness, they are confused, whatever, they'll have a fall. Don't always be considerate of what is stroke. Did the stroke start that caused the trauma, or did the trauma even cause the stroke? I did find a study, there was 2,800 admitted to a study. 4 of them met this trauma and stroke criteria. They found that 3 of them caused the stroke caused the accident. 1 of them, the accident caused a stroke. So just always kind of keep that in the back of your mind if things aren't adding up. Always pay attention to your details. I think there's an example of a patient who was lone, unresponsive. EMS picked up on one small detail of a hot coffee mug next to the patient. And that patient ended up getting TPA at the hospital because of that EMS information. That's the stuff that you guys brought to the scene, or sorry, to the hospital, the team was able to say, hey, that guy must have been well enough to make himself a hot pot of coffee and then had his episode and his scans were clear and everything. So he got TPA. So, the little things matter. I won't get too far into these pediatric examples, but just along the same lines. Don't let trauma distract you if things aren't adding up. Why did the trauma happen? And then pediatric stroke protocols are the same at CHOR, which is our downtown children's hospital with VCU. The stroke protocols are the same. Under 18, although we don't give it very often, they're still eligible. So treat them the same, treat them with the same urgency. Don't let things distract you. Pediatrics do have strokes and we do treat them. We do have our stroke protocols for our pediatrics. So I'll open it up for questions if anyone has any. I don't know if I'll have time to get to case studies, but that's okay. I planned it this way just in case.
All right. People have been active in the chat, but if anybody has any questions for Natalie, you can unmute and ask them now. Um, you guys are being
Okay,
quiet tonight.
cool. That's okay. I
If
can,
everyone's quiet,
oh,
you should do a case study, Natalie.
yeah, I'll run through, I was just looking through the chat. I'll run through, probably have time for two quick ones. So this one is just kind of a trust your gut, to you EMS providers. Don't, give pushback where pushback is deserved. Be patient-centered with your care. EMS was dispatched for neck pain. They came in to find 45-year-old female, obvious discomfort on her knees, leaning on the couch, ice packs on her neck. Her only complaint was pain in the back of her neck and her head. Kind of gives you, trauma vibes, strain of muscle vibes. Don't know if I'd really go to stroke right away. History of hypertension, diabetes on metformin.
If
Oh, on metformin.
like
Nothing really screams it right off the bat. Hypertension and diabetes are a risk factor, but again, not super neuro right away. Fast stroke scale, negative. All she had was that neck and head pain, no other things. So EMS treated it as neuro. They suspected stroke. Felt like they were dismissed. They took her to a primary stroke center. Felt very dismissed in the ER. They didn't think she was a stroke. Ended up having a pretty decent subarachnoid hemorrhage on imaging. So she was transferred to a comprehensive stroke center for further management of her her hemorrhagic stroke. So just trust your gut, be an advocate for your patient, take things like this and apply them to the field, and give pushback where pushback's deserved. And for this patient specifically, they were right. She was having a brain bleed, even though it was just some pain in the back of the head and the neck. And then I'll do this one. A 72-year-old male had a little onset of a black spot in the right eye, went to a primary stroke center, progressed to total blindness throughout the day. And I think after he got to the primary stroke center, it progressed to that total blindness. Only history, AFib on Eliquis, and hypertension. They referred him to VCU for ophthalmology for possible detached retina. He came, got a full stroke workup, stroke alerted, and we do a full stroke workup on on people when they come in, whether they're observation or TIA, anything, we do the full workup. He was outside the window for last known well by the time he got there. The blindness ended up resolving completely on its own, thank goodness, overnight on his admission, but his MRI did show a stroke. So just, again, going to show you, like, all he had was the blindness, which is part of that B fast, why the B is in there. All he had was that black spot, progressed to blindness, and it was a stroke on his MRI. So all this stuff matters. I hope you learned something. Thanks for having me. And stroke team, we're always available. If anyone has any questions, needs resources, anything like that, we're happy to give it from VCU's standpoint.
Well, thank you, Natalie, very much for your presentation tonight. Does anybody have any other questions for Natalie or anybody on our stroke team? I know there's been a couple of questions in the chat, but I see that Lori and Stacy are answering them as we go.
Thank you, guys.
But if anybody else has any questions, now's the time. Otherwise, I think I fixed everybody's name, so I know who everybody is. And I will award CE this evening, so you should see it on your CE report tomorrow. We had 170 people register for this class, so I feel like there's a lot of people who need CE before the end of March. So I won't delay you on being able to see it. But thank you guys so much for coming tonight. We really appreciate it. I'm still planning to do something in the month of March. It'll probably be again near the end of the month, but again, I'll get your CE up to you as best I can. If you do want a copy of the slides, I do have them sitting on my computer here. So feel free to email me at my VCU Health email, and I can send them out to you. If you guys are interested in doing any stroke training in your agencies, we can always come out and do that. We've got a great team that can do that as well. I know Natalie loves to travel, so uh, but otherwise, thank you guys so much for coming. We really appreciate it. And we'll see you next month. Have a good evening. Thanks, Natalie. Great job.